Welcome, fellow psychology enthusiasts. By now you know how these recordings work. Please have your textbook handy along with your Jeopardy list and something to write with and on. This lesson serves as your class notes for the chapter. Please take advantage of videos and other resources provided in D2L content for this chapter. Specifically, the video titled The Grieving Process echoes what your textbook says about how we all grieve differently. Additionally, the link to Real Stages of Grief should be incorporated into your epilogue notes. You are always welcome to ask me questions for clarification, especially when we have a recorded lesson. We have reached the end of our course. Yay! Let the celebrating begin. This final chapter is about death, dying, and the grieving process, a very difficult topic for most people to think about and discuss. In this chapter, we seek to explain some of the psychological factors in death. The whole chapter focuses on thanatology, which we will define in a moment. Additionally, we'll examine how death is perceived across the lifespan by examining people of various ages. The work of Kubler-Ross is one of the most well-known theories regarding death and dying, and we'll compare this to more modern ideas. Last but not least, we will examine different types of grief. Let's get started. Get your Jeopardy list handy as we are going to define our first Jeopardy item. Death is a difficult topic for most people, and it is not something we usually feel comfortable talking about. Yet, grief could be innate for us, and denying death leads us to feelings of despair. Often, death causes us to have a greater appreciation of life. However, we can take the stance that there is hope in death, that we have choices in dying, and there is affirmation of life. This is the study of thanatology, examining death and dying with a special focus on the social and emotional aspects, page 573. This chapter focuses on hope as a major theme and is used within the context of hope for life after death, hope that the world is a better place because someone lived, hope that death occurred for a reason, and finally, hope that survivors rededicate themselves. As a personal example, I lost my cherished mentor during the summer of 2014. I can attest to the positive framework presented in this chapter in that I have looked for hope in his death. He made my life and so many others' lives better just by being himself. I have hope and a renewed purpose in my life by carrying on his legacy through my teaching. He continues to inspire me on a daily basis, and I do my best to pass along his love of psychology to others. This is why I chose an image of a paper crane for this slide. Traditionally, it symbolizes hope and healing during challenging times. Let's examine how death is perceived across the lifespan. As you might imagine, it is difficult for young children to understand the permanency of death. Because of this, they may not be sad initially when someone dies. They also cannot understand the logical reasons why someone has died. Remember the obstacles to logical thinking we discussed as part of pre-operational thinking? Children are greatly impacted by family members' attitudes, so it's important to listen to children and show compassion. Children who are pre-operational are very literal, so it doesn't help to tell them things like, Nana has gone away on a trip. They will take you at face value with a statement like this. Egocentrism also plays a role in that preschoolers may believe they actually caused the death of someone through unkind words or thoughts. It is not until children reach middle childhood and become concrete operational thinkers that they understand the specifics about death. No matter the child's age, you should answer questions honestly at that child's level of comprehension. Every child will be different. Remember differential sensitivity? The way you respond to a child should be individualized to his or her needs. Teenagers are greatly affected by adolescent egocentrism and may believe that they are immune to death. Quote, it happens to others but not me. This is closely related to the invincibility fable we talked about in the adolescent chapters. Because of this mindset, they often engage in terror management theory. They cope with the anxiety they feel about death by defiantly doing whatever's considered risky. Turn to page 578 to see a detailed definition. Essentially, death brings with it feelings of terror, which we manage by how our culture has taught us to cope with it. It is common that a fear of death builds throughout early adulthood, reaching its peak at midlife. During midlife, we begin thinking about how much time we have left. We start making decisions and plans, which helps us to accept death. When someone passes away, an adult's reaction is directly connected to the deceased person's age. We are greatly affected if we consider that person too young to be gone. Sometimes our attitudes about death are irrational. We fail to make necessary health changes by ignoring life-shortening habits or focus on details to convince ourselves that somehow our situation is different. As you approach late adulthood, your own death takes on a sense of appropriateness, resulting in less anxiety and more hope. This doesn't mean that you give up on living. In contrast, it's actually a sign of good mental health to accept mortality and show concern for those who will live on. Again, we see the power of generativity, integrity, and engaging in a positive life review. Connecting with family becomes more important. Turn with me to page 582 in your book. Although it may sound paradoxical, people everywhere hope for a, quote, good death. There are 6 main characteristics that embody a good death, see page 582, and some might add control over circumstances and acceptance of the outcome to the list. However, this is dependent on the individual and culture, so defining the exact elements of a good death becomes difficult. Look at what we are doing. Most times, instead of accepting death, we attempt to fight it. We avoid it and deny it. What can help us escape that and instead experience the elements of a good death are honest conversation, hospice, and palliative care. Let's move on to the work of Kubler-Ross, who focused on how people cope with and confront their own death. This is a Jeopardy list item. In 1960, Elizabeth Kubler-Ross engaged in conversations with terminally ill patients within a Chicago hospital. Based upon these conversations, she identified emotions that dying people often experience. She divided those emotions into a sequence of 5 stages. Let's examine those as they are outlined on page 583. Stage 1 is denial, often embodied as shock. This denial acts as a buffer, giving the dying person time to wrap his or her head around what is happening. A common statement is, "This can't be happening." The dying person may even pretend that it won't happen, saying, "Everything is fine." Stage 2 is anger, and this is where the dying person experiences the full force of emotions in relation to dying. The person can direct it at someone or diffuse it by taking it out on everyone. Anger can also be internalized. Stage 3 is bargaining, and you hear statements like, "If I become a better person, maybe I'll get better." The person is trying to postpone the inevitable. Moving into stage 4, we have depression. This is preparation for acceptance and the initial realization of what is about to happen. The full reality of the situation has hit. "What's the use of trying anymore?" could be a common statement. We see classic symptoms of depression such as sleep disturbance, worrying, crying, and difficulty concentrating. Finally, stage 5 is acceptance, which is the beginning of the struggle with death. This is your point of demarcation for reconciling with the past and moving forward into whatever's next. The person may show an increased sense of energy and need to set goals or get things in order or return to previous stages. Kubler-Ross never intended for these stages to be applied to loved ones of the dying person. Yet counselors who came along after her started using them for that purpose. Kubler-Ross's work has come under fire as many researchers who came long after her have failed to find any sequential stages to a dying person's approach to death. As a matter of fact, there's next to no scientific evidence that has shown the existence of the stages or that everyone goes through them. Thanatologists are quick to point out that if these stages are experienced, they are different for everyone, and acceptance may never be reached. Herein lies a lesson. We need to realize that each dying individual has emotions and needs that are unique to him or her, and they may not be what we expect. Rather than cutting off a dying patient from daily life, we should allow each person to respond to death in his or her own way. Over the past decade, there's more of a focus on grief as an individualized process, that there's no specific timetable, and that many people find their lives are better after going through grief, something we call post-stress growth. Again, we return to the work of Maslow. Rather than emphasizing a set sequence, Maslow simply states that all of the levels in the hierarchy are important throughout the dying process. See page 583. Maslow later came up with a sixth stage called self-transcendence, which focuses on accepting death. So how can we best care for and support those who are dying? As mentioned earlier in this lesson, this is where hospice and palliative care come in. Cicely Saunders began modern hospice care back in 1950. She wanted terminally ill people to have a place where they could spend their last days in comfort. The overarching theme in hospice care is to relieve pain and discomfort. Measures to delay death are avoided. Two principles of hospice care include respecting patient autonomy and decisions, and including family members and friends by way of teaching, guiding, and counseling. Many people are unaware of hospice services or are unclear about what these services include, so awareness is the first step. Table EP2, page 585, echoes what you see on screen as barriers to hospice care. Palliative care is closely related to the goals of hospice care. This type of care seeks to relieve pain and suffering. Turn with me to page 587. Determining exactly when death has occurred is more difficult than it sounds. Historically, it was the cessation of heartbeat. Then in the 70s, it was when brainwaves ceased. That has also been called into question, as evidenced by table EP3. So even though we have used the cessation of brainwaves as a definition since 1980, we now have more modern measures that can prolong life, even when there's no conscious thinking. We need a more precise, updated definition, but experts are still unsure as to what that new definition should entail. For example, in a research survey, most families, 96%, were told that their family member was brain dead, but only 28% were able to provide a completely correct definition of what that meant. Many of them confused it with coma, but a coma is a state from which a person can emerge. In their study, 63.5% of the families first considered the patient dead when they were told the patient was brain dead, whereas 21.8% first considered it to be death when the machines were turned off and the heart stopped. Nearly 60% of the families made statements indicative of believing the patient was still alive even after being told he or she was brain dead. All of this shows us that the concept of brain death is confusing, both to the general public and healthcare professionals. Perhaps rather than focusing on explaining what exactly brain death means, it may be best to focus on explaining the implications of the diagnosis or the patient's ability to recover. Let's take a look at some important vocabulary terms in relation to a person's preferences for what should happen in an end-of-life medical situation. Advanced directives outline your preferences regarding end-of-life medical care. These directives are written before such medical care is needed. The goal with advanced directives is to help caregivers avoid conflicts, but things are not always that easy. Do you remember the Terry Schiavo case? See page 591. We need to have open communication about these issues long before any crisis occurs. Let's define a DNR first. See page 587. This is your preference not to be revived if you suffer cardiac or respiratory arrest. If you are unable to express your medical preferences, a living will, page 590, is a document that outlines your wishes. A healthcare proxy is someone you designate to make medical decisions for you if you are unable to do so. Even when these measures are in place, there can still be conflict or problems, as outlined in Terry Schiavo's case. Check D2L content for a sample of the 5 wishes, a document that helps you outline such things as your healthcare proxy, the kind of medical treatment you prefer and don't prefer, as well as comfort measures, how you want others to treat you, and what you want your loved ones to know. It's a living will that focuses on personal, emotional, and spiritual needs in addition to medical needs. See page 591. As you might imagine, there is no one way or correct way to grieve. I think it's important for us to remember that grief is a normal human emotion. To be exact with the definition, it is the profound sorrow that we feel after a loved one has died. It is personal, and it is unpredictable. One of the best analogies compares grief to a roller coaster, with highs and lows as part of the process. The way in which you grieve is profoundly affected by your culture, childhood experiences, and personality traits. Please be sure to watch the video entitled The Grieving Process in D2L content. Let's move on to your next Jeopardy item, which outlines that there are many different types of grief. Complicated grief gets in the way of normal daily life because we cling to sorrow or are struggling with contradictory emotions. It continues for too long. This affects about 10% of mourners. Have you ever known someone who did not seem to grieve after a loss? This is absent grief. When prolonged, this type of grief can trigger physical or emotional symptoms. Think about the internalization we talked about earlier this semester. When those who experience loss are not allowed to mourn publicly due to culture or social restrictions, we call this disenfranchised grief. For example, imagine a divorced couple. If Bob's ex-wife dies, he may be excluded from the memorial service, even though he may still care about his ex-wife. When the process of grief is interrupted, we call this incomplete grief. This is often the case after a murder or suicide. All of these types of grief show us that many people do not experience grief in a linear fashion. For example, depression is not universal. In one study, only 15 to 35% of widows and widowers showed signs of depression. Additionally, not everyone rebounds quickly. The time frame is different for everyone, and some people never accept the loss. Let's move on to your last Jeopardy item. So how are grief and mourning different? Grief chips away at you. It is a process. But mourning gives us the chance to rebuild. Mourning is a social and cultural process to help us move past the grief we feel. It is a public showing of our accepted ways of honoring the dead. See page 594. When we engage in grief work, we allow ourselves to experience emotion, to mourn, and then work toward wholeness. Grief creates division and brokenness, whereas mourning brings reassembly and a feeling of wholeness. There's no specified time frame for this. What if you need some extra help with this lesson? Ask me for help. I'm more than happy to sit down and work with you one-on-one. I'm also available through email and my office phone. The video supplements what your textbook outlines regarding grief work and how this is an individualized process. The Real Stages of Grief link shows a contrast between the work of Kubler-Ross and modern-day theory, in addition to providing tips for coping with grief in a healthy manner. Last, you have a sample of the 5 Wishes Living Will, which can help give you a better idea of advanced directives, as well as spur you to think about your own preferences. Please let me know if you have questions. I'm happy to help.